Morning, everyone. Welcome to the webinar, COVID-19 webinar of the National Institute for Occupational Health, the NIOH, a division of the National Health Laboratory Services. Our topic today is ethical considerations for occupational health and safety personnel in the workplace around COVID-19. And I think a very important topic to deal with. And I'm going to, without further ado, hand over to my colleague, that is Dr. Tanusha Singh, in order to just do the welcome. Thank you, Tanusha.
Thank you so much, Ashraf. Good morning, everyone. A very warm welcome to all of you on behalf of the National Institute for Occupational Health, a division of the National Health Laboratory Service. Welcome, participants, to today's session. Thank you for making the time. And a special welcome to our guest speakers today, Dr. Kubeka, Dr. Coombs, Dr. Fox, and Dr. Inkwanyana. Thank you so much. We really appreciate you taking time from your very busy schedules to share your knowledge and experiences with us on this topic of ethical considerations for occupational health and safety professionals during this COVID-19 outbreak. It is indeed a very important one. And I must thank the Occupational Medicine section and Ms. Mangani from NIOH for putting together such a great program for us today. Despite us working under enormous pressures during these very challenging times, our actions and decisions must still be done ethically nonetheless. So we look forward to the presentations today and the lessons learned from the COVID-19 outbreak. Before I hand over to Ashraf, I would just like to take the opportunity to thank the entire NIOH team in organizing the session, and to the team of panelists who will be in the background answering the questions during the session. Thank you so much. Ashraf, over to you. Please kindly take us through the rest of the proceedings and a few of your virtual housekeeping rules.
Thank you very much. That was Dr. Tanusha Singh, who's the head of our COVID-19 outbreak response team, that is the COVID-19 Occupational Health Outbreak Response Team, as well as head of the Immunology and Microbiology section here at the NIH. The next thing to remind you of, colleagues, is that this is an ethics CPD accredited webinar. And it has been accredited by the Health Professional Council via the WITS Health Consortium, and as well as recognized by NIOH for 2 standard CPD points, not ethical ones. And NIOH itself, as you've seen on the slide, which will again be played at the end of the webinar, has allocated their own points according to their point system. And we are awaiting, in terms of the nursing practitioners, news from the Stellenbosch University STELMED faculty with regard to our application there for the CPD, ethics CPD points in particular. And my understanding is that from SADA, in terms of the dental practitioners, that there would be a recognition of the already accredited Health Professional Councils category. So we will confirm all of those. After the session, there will be a link sent out by a colleague in NIH in the communication section to you with a password for you to be able to do the online multiple choice questionnaire to qualify for the ethical CPD points. Some of the other announcements have been on the screen as well before we started, and I will make further announcements as we carry on. I would like to get to our presenters as soon as possible. Just one last reminder. At the bottom of your screen, you'll have the Q&A double bubble, right? The 2 little speech bubbles. Please, that's where you type all your questions. No questions in the chat bubble. The chat bubble is for general administration, other general questions, and just, salutations and highs and so on. But the Q&A is what our group of panelists, and there's quite a significant number of NIH colleagues who are online, will be answering your questions in the Q&A section, as well as our presenters. When they're not presenting, we've asked them to look at the questions and answer them as you are typing them in the Q&A box. And with no much further ado on that, I need to introduce you to the presenters, as Dr. Singh has already thanked them. So first, Dr. Brenda Kubeka is going to deal with the topic of ethical considerations during a public health disaster or public health outbreak. After that, we have Dr. Marie Coombs, who's going to deal with an overview of ethics in occupational practice and outbreaks. Dr. Frank Fox, who's going to deal with COVID-19 related ethical issues specific to occupational health practices, and that would be the occupational health services, both in the private, I guess, and public spheres. And then finally, Dr. Tabani Kwanyana is going to deal with COVID-19 medical legal considerations in an occupational health practice within South Africa, dealing with the liabilities and case law applicable there. So I'm going to ask my colleague, or rather our presenter, Dr. Brenda Kubeka, if she's going to share just her presentation. So I want to welcome her. And before I proceed with that, otherwise, Dr. Kubeka, Brenda, maybe my colleague Glenn can share on your behalf. You can just indicate what is your preference. Whilst that screen sharing is happening, and that would have to be maximized for presentation purposes, let me introduce Dr. Brenda Kubeka for you. Dr. Brenda Kubeka is co-founder of the Health IQ Consulting based in Johannesburg. She's an ethics and clinical risk lead in the organization. Her previous roles include being a chief medical officer for the Clinics Health Group. She's also worked at MedScheme as a medical advisor, and later as a senior manager responsible for overseeing clinical and operational excellence in hospital and pathology management divisions. Her experience also includes working as chief director at Mpumalanga Department of Health. She holds a medical degree from Sifako Makgatho Health Science University, an MBA from GIBS, and she holds various diploma certificates, including clinical ethics and media and medicine from Harvard Medical School. She's pursuing a PhD at the School of Public Health at Wits University. She serves on various board subcommittees, including that of the Cancer Association of South Africa, Leratong Hospital, and Health Professional Council of South Africa. She's published academic author and regular opinion piece contributor in local and international newspapers. And with that quite significant introduction to Dr. Brenda Kubeka, I thank you for joining us and contributing as our first presenter today. I hand over to you.
Thank you so much, and good morning. Thank you for the invitation and for the generous introduction. So as indicated, that my topic is looking at the ethical considerations during a public health disaster. Okay. So this is the outline of today's presentation. And basically, it's from defining public health ethics, and then looking at the ethical principles that are relevant in the pandemic, and then the various roles and responsibilities of the stakeholders and the conclusion. Just defining what public health is. It's the science of protecting the safety and improving the health of communities through education, policymaking, and research for disease and injury prevention. It basically came out as a response to epidemics and ensuring that the spread of the epidemics is contained. The goals of public health are to assure an adequate local public health infrastructure, to promote healthy communities and behaviors, prevent the spread of communicable diseases, protect against environmental health hazards, prepare for and respond to emergencies, and then assure that there is health services and there's adequate infrastructure and other supplies to respond to that, and research. Public health response to epidemics. as I've mentioned earlier on, that it was a response, public health was a response to epidemics, and it basically was a precursor to looking at water systems and making sure that there's clean and safe water supply, sewer systems, regulating the restaurants and workplaces, and ensuring that hazardous materials are disposed in a responsible manner, protecting the public, and also the reporting of infectious diseases, which includes surveillance, contact tracing, isolation, etc. We'll cover some of this later in the presentation. But what is important is just, taking it back to basics when we look at social determinants of health and COVID, which basically has presented a moral crisis. COVID-19 is a public global health emergency, and it has impacted on health systems, the society, and the economy. But what is important is that the health status and outcomes are influenced by social determinants of health. The socioeconomic status, the environment, whether we're talking about the environment at home or at work, the levels of and the quality of education also has an impact on health and on also accessing opportunities, which is also a social determinant of health, like unemployment. And also we know that, children also born to mothers who have a very low level of education, they also have poor clinical outcomes. So issues of access to care, etc. So this becomes very important as a foundation of understanding how our environment and impacts on the health status of the population and also the outcomes when we look at population health. Talking about the moral crisis, we've seen a number of newspaper articles and also discussions in the media regarding what COVID-19 has brought to our attention, basically elevating some of the ethical issues that we haven't been discussing in the country. The issues of the widening of inequality and the impact of that when it comes to unemployment, when it comes to clinical outcomes, when it comes to health status of the population. And also it's important also to look at the widening inequality and its impact on security in the country. Poverty is also important. I've already spoken about unemployment, the issues of corruption. I mean, we are hearing in the news the discussions about corruption in the procurement of some of the supplies that are relevant to COVID-19, etc. The most important thing that it has elevated as a public healthcare practitioner is the inequitable access to basic services like sanitation, like water supply, where we've seen some of the schools that were complaining that they didn't have access to clean water or access to water, and they also had poor sanitary services in the schools. Looking at public health disaster or emergencies and ethics, if you look at pandemic, it's basically, if you look at the first three and the last two syllables, it's panic. So this is what we saw, not just in South Africa, but globally. When COVID-19 conversations started and it was declared a global public health emergency, we saw people going to the shops and buying items. And this is because of uncertainty and fear and people not knowing what was going to happen and what was going to be the impact of COVID-19 in their immediate environment, which is the home environment, in the economy, in the availability of supplies, etc. And then these are the characteristics of a pandemic, the issues of changing circumstances. We've seen the lockdown regulations being adjusted from level 5 to where we're at right now, and probably that will be reviewed based on the changes in the public health space and how the infection rates are happening in the country. And then the rapidly changing recommendations, we see that when it comes to treatment that is being recommended for treating COVID-19, it's much better now earlier on, and the use of drugs that were not proven to be effective towards treating the infection. And planning and resource allocation. Obviously, when there is a pandemic, there's a huge demand and strain on available resources, whether we're talking financial resources, human resources, and it becomes important that the policymakers plan appropriately and ensure that the limited resources are utilized effectively and also in an equitable manner. Looking at COVID-19 and how it has impacted on the health system, it has disrupted health systems and services. We saw elective procedures in hospitals being delayed and some of the services not being provided so that the country could prepare for the increase and the surge in demand. It consumes resources that are set aside for routine care. As I've said, some of the services were subordinated, if I may put it like that, issues of immunizations, and some people were scared of even accessing care because they thought that they will get infected in the healthcare facilities. And then we just need to plan now for the increase in some of the adverse effects of limited access to healthcare during the lockdown period. So issues of restricted access, reassignment of human resources that we had expected. We saw that happening in the US, where you find that people that haven't worked in an emergency department, health professionals that are super specialists, renal care specialists, were working in the emergency department because of the increase in the service demand. So care was delayed, and then it did threaten human resource capacity, and I still think it does threaten human resource capacity, whether we're talking in the healthcare environment or outside in other industries, because of when people get infected and the need for quarantine, and also just managing, the spread of the infection in the community and also in the workplace. So that does threaten human resource capacity. Now, looking at COVID-19 as a public health emergency, there is a shift from clinical ethics to basically public health ethics. If you look at clinical ethics, it basically relates to the relationship between a patient and a healthcare practitioner. And this is governed by autonomy, the freedom to make decisions, the freedom to refuse care or to accept recommendations that is made by healthcare professionals. And then the important thing that the care provided must benefit patients and do no harm. And then justice issues, which basically looks at the fair distribution of burdens and benefits. Now, if we move to public health ethics, it's focusing mainly on public and population health outcomes, and at the same time also focusing on individual clinical outcomes. So it's important when it comes to public health ethics, the issues and the principles of trust. If you look at public health ethics, the relationship between the government and the public, and the importance of trust. Because when people don't trust the government, when communication is not forthcoming, when there is no transparency, when confidentiality is violated, people don't trust the government. So if they don't trust, they will not listen to the messages, and they will not also comply to the public health recommendations that have been made. And then it's back to basics. The issues of fundamentality is basically just going back to the basics as to what is important. And then justice again, we're looking at fairness, no discrimination, and procedural justice, transparent ways of doing things, etc. I'll talk briefly about the Bill of Rights, specifically to the access to healthcare, because I think my colleagues are going to cover this. In the Bill of Rights, it is stipulated that all citizens have the right to access care, but the right to access care does not necessarily mean that people will receive the care. If we think of an emergency, a public health emergency, there will be, there's an increase in the number of people requiring healthcare services, but the human resources and other resources are limited. So even when care is accessed, it might not be actually received because of resource constraints, etc. And the Bill of Rights does state that it's access to care guaranteed and to be provided within the available resources. So when there is a significant increase in demand, there is a need for rationing of care. The question that we're asking earlier on, and we are grateful that we did not get to that point in South Africa, is who gets the ventilator? In other countries, they've experienced that challenge where there were more patients requiring ICU care or to be offered invasive respiratory support, but there weren't enough ventilators available. So those are the some of the challenges that were faced and are faced by health practitioners and health service managers. But once again, even when the resources are limited, the decisions that are made must be ethical, and they must be defensible, and they must be fair. So if we look at the ethical principles that are important and relevant when it comes to public health emergencies, some of them I've covered them briefly earlier on. If we talk about justice, and you can see the news clip that I've used there, the recent one with PPE corruption and Judge Zondo that is sitting in that inquiry. It's issues of also procedural justice, which talks to transparency. And if you look at PPE procurement issues, it's the transparency, it's the fair access to opportunities, you know, etc. It's making sure that the interventions that are implemented are effective and they benefit the society, and there is no wastage, which is basically futility, wastage of the limited resources. Even when there is a public health crisis and the resources are limited, we still need to make sure that people are treated with respect and confidentiality is protected, the dignity is protected. And then also the issue of liberty. The fact that there is a public health crisis, it does not mean that now the government has the right to infringe on the individual's human rights, unless there is no other option. But at the same time, if you're looking at liberty and the public health crisis, there must be a balance between the freedom to choose and the freedom to determine your own end, and the trade-offs that have to come into play, and elevating some of the values like, community, because now it's a public health crisis. And basically, we are all interdependent, and solidarity becomes important. Solidarity at a national level, solidarity at an international level, we talk to cooperation amongst the different governments, and then ensuring that between the borders also the transmission of the virus gets limited, and then also that collectively, we safeguard the health of the population and also the security. So if we look at, issues of reciprocity, the principle of reciprocity, I'll just give an example that during lockdown level 5, essential workers, whether working in a grocery shop or at a hospital or, a firefighter, they had to go to work. But during that time, the nursery schools were closed, But yes, people have taken an oath that they will go to the hospitals and provide the care, the healthcare workers provide the care because they have signed up for that. So they basically have to show up. But in abnormal circumstances, also societies need to ask themselves that when people show up and there is also a high risk of getting infected from COVID, what is the society supposed to do to sort of reciprocate and also support, those essential workers and making sure that their children are taken care of, for example, etc. Looking at the rights and ethical principles and to be protected, but the reality is when it comes to public emergencies, notifiable conditions, certain information needs to be shared. So the important thing is that relevant information must be shared that is necessary to achieve public health goals. And then if for whatever reason there is a need to infringe on the privacy, there must be a guarantee that there is no less intrusive means to protect public health, but to violate privacy for the benefit of the public. And then the benefits must always outweigh the harms. And then public education must be provided to ensure that disinformation, misinformation, fake news, like in social media and in other spaces, those get managed. And also the impact of disinformation, is reduced. The negative impact of that gets reduced. Because if false information gets out there and it's about, let's say, confidentiality or the rights of the patients are violated, people are not going to show up because they'll be so scared that if I go to a particular, healthcare facility, all this information about me will go to a place where I'm not comfortable and I don't even understand why my information will go to those places. So it's very important to invest also in public education. That also includes in a work environment. Now we'll talk about the international health regulations. As I've said that when there's a public health crisis, there is collaboration between the different governments, but also the government has a responsibility, every country has a responsibility to ensure that they exercise their health powers in a transparent, non-discriminatory manner with full respect for the dignity, human rights, and fundamental freedoms of persons. Looking at COVID-19 now and ethical dilemmas. If we think of lockdown regulations, we had to strike a balance between trade, which is the economy, versus lockdown regulations, which were aimed at protecting the public, ensuring that COVID-19 is contained, and also ensuring that the healthcare system is geared enough to respond to the surge in demand. Issues of individuals refusing care when they are suspected to be COVID exposed or COVID positive, and then balancing that, the individual rights, and also the responsibility that health establishments or health professionals have to ensure that that risk is managed, and also to ensure that public health is protected. And then the issues of health workers' rights and, the duty to care, and also balancing that. There was an element of fear with some of the healthcare workers, fear, but that also needing to be balanced with the duty towards the society, the duty towards healthcare, towards patients. And those are some of the cases that we are dealing with in other spaces where some of the professionals actually refuse to look after some of the COVID positive patients. And then the allocation of scarce resources. If you look at the US, New York, they made a decision that they're going to graduate their fourth-year medical students sooner so that they can go out there and work and be able to respond to the operational demands of COVID-19, and also the repurposing of healthcare workers, as I've mentioned earlier on, where you found people that haven't worked in the emergency department or ICUs working there because of the shortage of human resources and the increase in the service demand and the burden. And then I've spoken about operational demands in healthcare space, but operational demands in a business environment where now there is a need to strike a balance between doing what is right and also because of dual responsibility or dual loyalty, and also people thinking or professionals thinking that we have to preserve the operational capacity of the business. So these are the ethical dilemmas that get faced or that are presented by COVID-19. And then the other one being research. We've seen quite a number of journal articles being published prematurely and some of them being withdrawn because of processes not being followed and because it's a public health crisis period, and also some request of research to be conducted in quarantine centers, etc. And those are some of the ethical challenges and dilemmas and conversations that needed to be held to ensure that the public is protected, and also that authorities also act responsibly. Now, talking about ethics consultations and committees, I've already mentioned that COVID has elevated some of the ethical issues that we're not discussing, issues of inequality, etc. The reality is the impact of COVID-19 has affected the economy in the country. So we're seeing people losing their jobs, being retrenched, we're seeing people salary being cut and hours being cut, etc. Employers also introducing tools to make sure that people are screened before they enter their workplaces, and also some clinical decisions that had to be made by healthcare professionals in a work environment. All these issues, ethics is should be a fundamental component of those discussions. Like, for example, how to decide whose salary needs to be cut. Is the CEO's salary remaining the same whilst we're cutting, the salaries of the lower level care workers? When it comes to retrenchments, do we just send text messages and tell people that they've lost their jobs, or we do it in a responsible and a humane manner that embraces the principles of Ubuntu, And then the health checks, I'll talk about later on, briefly about information management, etc. But ethics consultations and that support and having those committees to ensure that decisions that are made in a work environment, decisions that are made when it comes to resource allocation, and even in healthcare, when resources are limited, we need to ensure that they are done in an ethical manner and in a way that it's fair and also that is defensible. So justifying health, public health interventions. If you look at those pictures, I mean, we see if you go to a mall, normally it should be the security guards that are checking people's temperatures or screening people before they go in. At the bottom there with a temperature of 32.7, that's my temperature a few days ago. And the question is, what does it really mean when you have someone that is checking your temperature that does not understand what they are looking for? And when do you raise an alarm? When do you, how do you manage even the tool that you're using? So it's important to make sure that the interventions must be effective. They must be necessary and essential. There should be least infringement on human rights, and then public justifications. So I'm just going to ask that to all the delegates, you ask yourself, look at what you've put in place at your workplace. And the question is it the right thing to do? Is it being done, whether it's a procedure conducted by the right person? Do people even understand what they're doing, why they're doing it, and how to escalate and who to escalate it to? Is it effective? Is it even worth the energy exerted in doing some or implementing some of the interventions? I've said and mentioned the issue of allocation of scarce resources. Ethically, I've said that it must be done ethically. So there are questions that are being raised in different environments. Do we give access to a limited resource, the sickest person first, or the most likely person to benefit from it? But when we say the most likely person to benefit from it, who is that? If now we look at inequality and the fact that inequality is a social determinant of health, and the fact that the poorer the person is, they will have more comorbidities, etc. So these are the questions that we need to ask ourselves when we want to make ethical decisions. Is it a first come, first serve issue? If it's first come, first serve, if the person is staying a kilometer away from the hospital and then the other one is staying 20 kilometers away from the hospital and they have to raise the funds to come to the hospital and it takes them 3 months to get to the hospital, is that fair when we use the first come, first serve? Random allocation and lottery, the ability to pay within the challenges when it comes to ICU bed availability in South Africa, where we found that there were more beds in ICU in the private sector than there were in the public sector. But the good thing was that in Gauteng, I can only speak for Gauteng Department of Health, these beds, the capacity was combined to ensure that there is equitable distribution and also access to critical care services. So now we're going to talk about the 3 duties for healthcare leaders. For me, these apply to leaders also, even outside of the healthcare environment. The first one is the duty to plan and to manage, basically managing uncertainty. It's to plan and make sure that there is adequate response mechanisms, and then that the emergency plans are there, they are in place, and then also plan for ethical challenges and have protocols and guidelines that assist people that are supposed to make decisions or implement those decisions to do them effectively and also in a fair manner. And then the duty to safeguard, basically supporting workers and protecting vulnerable populations, making sure that the work environment is safe, reducing the risk of occupational harm, and then protecting vulnerable populations like the disabled, comorbid, elderly, and the homeless. Once again, we go back to the social determinants of health. Those are some of the life lotteries that people do not choose to be born from or to come from a certain environment. People do not choose to be born with certain disabilities, etc. But by virtue of having those limiting characteristics, they get to be more prone to suffering from chronic conditions, diabetes, hypertension, etc. So those populations, they need to be protected. The duty to guide, to ensure that there's contingency levels of care and crisis standards of care. So where there's resource scarcity is just looking at where else can those resources be mobilized from. We saw in South Africa that some of the PPE, like the face shields, were being manufactured by some of the universities and the private sector, and we saw both academia, not both, it's the 3 parties, academia, private sector, public sector, working together to ensure that there's adequate PPE supply in the country. Making sure that there are protocols to guide and also ensure that we don't waste the limited resources. And then where there is a need for guidance, especially when it comes to ethics, those platforms or those resources must be made available. When it comes to ethical dilemmas, no one person can make a decision, come to a fair decision by him or herself when it comes to an ethical dilemma. Just imagine if, let's say, it's a patient that needs a ventilator, and there's 4 patients that need ventilators, there's only 1 ventilator available. If it's only 1 person making a decision, that decision might be influenced by bias. 1, people from informal settlements, anyway, they are poor, excuse me, they won't be able to take care of themselves post-discharge, maybe I shouldn't, you know? And then it could be someone else saying, people that are over the age of 40, maybe it's an ageist person, people that are over the age of 40 or 50 are not going to benefit, you know, it's better to put someone that is younger, etc. You know? So that is why it's important to make sure that when you face an ethical dilemma, you should always involve other people. And if those resources, where maybe there's an ethics advisor or there's a specific committee, and even if it's a COVID-19 committee that was specially formulated, you consult, we make sure that we consult to make sure that we make decisions that are fair, and then all that needed to be considered, the law, what is fair, and also previous experiences can be considered to inform the decisions. Looking at public health ethics, I've already covered the issues of equality and equity, and it takes us back to that multicolored slide of the social determinants of health, because some of them are life lotteries, and most people did not choose to be in the spaces that they're at, but it has an impact on their health and their health status. So now we'll talk about roles and responsibilities of individuals, health workers, authorities, and the society. The duties of healthcare workers, they have a moral obligation to provide humane care and also not to blame patients when they come and you know, they've been exposed to COVID or they're COVID positive, irrespective of the history they provide. And then the professional obligations to make sure that information is treated, you know, with due care, and the privacy, confidentiality is maintained, documentation is done appropriately, because that documentation is a legal document, but at the same time, it's important for continuation of care, and it's evidence that care was provided, etc., to make sure that care that is required to the patient, by the patient, or a group within the available resources is provided, and also to uphold, you know, the social contract and the employment contract. But once again, the issues of dual loyalty, being loyal to a patient and also being loyal to an employer, you know, whether we're talking about healthcare workers that are employed in the private sector or public sector. So that is important to be aware, but what is the most critical is understanding the issues of power dynamics and the fact that in all those interactions, patients are the most vulnerable. So it means patients deserve more care in ensuring that their rights are not violated, irrespective of the pressure that some of us might receive from you know, our employers. And then clinical data controller obligations, you know, once again, these are clinicians, is to make sure that clinical information is, the privacy is upheld at all time. It's kept securely and stored in a way that no one can access who is not supposed to access it. And then issues of disposal, there must be policies, like for example, the screening forms where people come in, they fill in or they put their personal identifying information and they answer the questions. And that if that information gets transferred to an electronic format, what happens to those papers and who gets to dispose of them and how they get disposed, to ensure that we also protect, you know, privacy. And then processing of personal data must always be fair and lawful, and it must be done for a specific reason, and it must be also subjected to a specific period. The important thing is that privacy and security of data, clinical information are not just about protecting that, they are about protecting people. And then obligations of individuals is to seek diagnosis and treatment when people know that they've been exposed to COVID-19 or they experience COVID-19 symptoms, to ensure that they abide by the recommendations and the treatment that has been prescribed by health professionals. take responsibility in preventing the spread of the disease, but more importantly is telling the truth, because when people don't tell the truth, which is basically history that also informs the decisions that will be taken by the healthcare practitioner, it compromises, the care that is going to be provided, and also the capability or the capacity of managing the public health crisis or emergency. And then obligations to workers is to ensure that the tools and protocols are provided, not just the ones required for doing the job effectively, but also for ensuring that the work environment is safe. And then the protection of the workers and support to be provided, especially right now with COVID-19 and the mental toll that it comes with, and then the fear and the anxiety. That support is required for employers. This, I'm just sharing the impact of the pandemic on the health professionals. It's depression, it's burnout, it's moral distress, the fact that people have to make decisions based on limited resources, and the post-traumatic stress disorder, etc. The obligations to the society. It's important that authorities or authority figures, they communicate the importance of compliance with the public health guidelines and recommendations, and then that people are aware of the reasons, because if people don't understand the why, it's difficult to uphold those recommendations. And then also discuss the benefits and the risk of complying and not complying. And there must be mechanisms to review decisions as the public health situation changes. I mean, we see the president addressing us now and again, and the changes in the restrictions. And I think the same conversations also happen in the workplace. And lastly, address stakeholder complaints and uphold fairness at all times. This is today's announcement. Vodacom has zero-rated the new COVID Alert South African app. And once again, we are in an unequal country. So if apps are developed, and even in the workplace, we must make sure that the people that cannot afford data have the same access to those technological solutions that are being provided in the workplace and in the society. In conclusion, public health emergencies, they call for the focus on population health and outcomes, but it's important that we protect the individual rights and only subordinate them when it is justifiable and there are no other options. We need to go an extra mile in protecting the vulnerable people. Ethics consultations facilitate procedural fairness and prevents moral harm and unintended outcomes. We need to prepare for adverse effects secondary to the pandemic response. For example, the fact that childhood immunizations have been missed, some of women have missed their contraceptive appointments, etc. So that will have an impact later on when it comes to public health, and that should also inform the planning. So the focus when it comes to public health emergencies should be on the greater good, which is the utilitarian theory, but whilst minimizing harm to the individuals. We're not sacrificing individuals for the benefit of the community, but we need to be able to strike a balance between those two. Thank you.
Thank you very much to Dr. Brenda Kubeka for her contribution to this particular webinar and the first presentation. And just a quick feedback to you, Brenda. We have Jacob Hutchinson saying this is probably one of the best presentation ethics that I've been privileged to attend, and he says thank you. So we're slightly over, and I now have to introduce our second presenter, Dr. Murray Coombs, and I'm going to just check with Dr. Coombs if he is online and can share his presentation. We have approximately until about, what is that, 12:15 for, hold on, have I got this wrong? No, 11:45 approximately for your presentation, Dr. Coombs. And whilst Dr. Coombs is just preparing his slide for sharing with us, a brief introduction. Dr. Coombs has an MBCHP, Diploma in Emergency Care, Certificate in Aviation Medicine, and Diploma in Occupational Health, and is a specialist in occupational medicine. His professional career, in 2018, he retired from corporate practice, was the past president of Medichem, the chair of the ICO, I think that's the International Conference on Occupational Health, SC on chemical industry, I think that's the subcommittee, 1999 to 2018, the corporate career as specialist medical advisor to international companies. And from 1985 to 1989, I'm going in reverse, private practice as an occupational medical practitioner, affiliations with professional organizations, which is both the Health Professional Council of Africa, ICO, Medichem, and SASOM. Career highlights is the United Nations Task Force on HIV/AIDS in the Workplace, the World Economic Forum Task Force on Scaling Up Occupational Health and HIV/AIDS Response in Africa, ICO board member and task group for ethics, president of Medichem, chair of the subcommittee of ICO, and the Dow Chemical Health Service leader, Europe, ME, Africa, and India, and Unilever medical advisor, ME, Africa, and Turkey. And lots of publications, and mostly on biological monitoring and medical surveillance. So welcome, Dr. Coombs. Thank you for joining us today. I want to hand over to you if you could just share your slides.
Yeah, I presume you can see the slide, otherwise...
Not yet, no. I think you would just need to use the share screen at the bottom if your slides are already open, and then to choose the particular set of slides that it should be open already, yes. Yeah, and then if you could just maximize. Thank you very much.
That's it. Okay, thank you. Well, let me start then. Thank you, Dr. Kubeka, for setting the scene there. I'm going to go a bit more into the realm of occupational health now, and then for the practical considerations, I'm quite sure the next two speakers, where I'm going to be slightly more philosophical in the ethical base, will capture some of the practical considerations. So I'm going to start off with, it would be nice to think our ethics will be no different during a crisis. But of course, some of the things that we've already heard from Dr. Kubeka, and the slide I have here on the death rate as one example, is prior to COVID, we already had a death rate of about 1,000 people per day in South Africa. And a lot of discussion can take place around what did we do around lockdowns and public health and private health to consider the plight of those people. I'm going to use basically to cover the two references I give you, ethics from the ICO web, which is an international ethics guideline, about 32 pages, that would help occupational health professionals, for those who don't know. And the second part is going to be ethics in crisis management, a course run that is a 4-day course that people can attend if they're interested in. I'm going to start off with ethics for occupational health professionals, and then have two nice Latin things, primum non nocere, basically the same as the duty of care, first do no harm. But then I'm going to add to that omnem questionem, which in a crisis, but also your day-to-day life, is question all. Make sure you question what the response is needed from you as an occupational health professional, and even more during a crisis. I'm going to cover those three headings, personal, professional, stakeholders, and somewhat move into occupational health. So ethics, I'm using the base of the medical part of doctors, but every other profession in occupational health and safety will have a similar line. In this case, we have for doctors, the Health Professional Council's ethical guideline, that occupational health, the local society, and then the International Commission on Occupational Health, which we then govern ourselves from global to local. But we also have personal ethics, and personal ethics is that ethics that a person identifies with respect to people and situations they deal with in their everyday life. And very clearly, I want to state it very early in this discussion that ethics also brings in a set of liabilities. It starts off with, as we heard already, duties and obligations, but there are also liabilities. So for personal side, there's a personal liability for your professional medicine, or be it health and safety. There's a professional liability, and particularly because we are deemed experts in occupational health, we obviously can also become expert witnesses, which brings in both a liability in that regard as well. The next one is business, the business ethics. And in this case, I want you for a moment to think not of the business that you contract to or the client-patient relationship, but think of your own business, the practice, the business that you work in, and what is the appropriate business policies and practices that you have to have in that ethics. And I'm going to build most of this lecture on that ethics should already be a base of your organization, yourself, your business, your practice. When crisis hits, you don't have to go and find your ethics, you already have them. So in the case of your own business, you're going to have to look at your corporate governance, your discrimination, your social responsibility, your fiduciary responsibilities. So you'll see over the next few slides, there'll be a thumbs up and a thumbs down to just consider this, what happens if I don't follow these rules. And then we'll go into SASOM and ICO, occupational health, and not in great depth or length, within a half an hour. It's basically just even to cover the ICO 32 pages is going to be long. But we don't live in an island, so it's just not us and our practice, but also our stakeholders. And I'm just going to touch on 4 levels of stakeholders, which Dr. Kubeka and probably the other 2 presenters will also touch on, I'm quite sure. So industry or companies also have a system of moral and ethical beliefs that guides their values and behaviors and the decisions of these organizations, and very often called business ethics, which some people may call an oxymoron. For labor, we have the International Labour Organization, which again uses phrases and concepts of equality, dignity, social science, and integrity. And you'll see how this moves into the societal discussion. It's about good faith, honesty, impartiality. It's a respect for a set of principles, which already tells you that you need to have some sort of a base of principles documented somewhere so that you can build onto that. Governments also have, as part of their practical jurisprudence or philosophy of law, but again, it has this positive, this yin and yang, positive and negative. It covers issues of honesty and transparency, but it also has to cover bribery, corruption, and impropriety, open government versus conflict of interest, and therefore somewhat of a legal ethics in government. We then land up with an individual, and the individual within its own society. And again, here we believe as a society, as a larger ethic, that we want to have values of social responsibility, of solidarity, of social utility, that we want to base the way we interact with each other on a rational, moral, egalitarian, pluralistic, or democratic society. And all of this are built on pillars of human rights and human dignity. So we clearly need to understand this deeper ethics across our stakeholders. But I want to move into the occupational health side. So clearly we have to look at the two ourselves and our interaction with business. And so we're not surprised to find that 90% of the Fortune 500 companies have a code of ethics that apply to all their employees. And this code of ethics helps to address the unique business situations that people can land into. It's often done within organizations to just make very clear to employees and members of the organization that you cannot claim ignorance as a defense for your unethical conduct. So again, that yin and yang, positive and negative. But for a professional code of ethics, as we will have in occupational health, it sets a standard for us as a member of the profession of how we want to protect the public's well-being and how we want to interact with each other. It is, however, not a static, this is the last paragraph, remaining ethical is not a static issue. And so during a crisis, it's time to review and evaluate, but at any time, it's a good thing to review and evaluate your standards of practice that you set out for yourself. So a successful business or a partnership is foundation of trust. There are 6 ethical terms, and this you can find under www.bomi.org. Ethics, values, morals, integrity, character, laws, and it again highlights that what ethics in principle means, it refers to a set of rules that describes our acceptable conduct in society. It serves as a guide for moral daily living. Ethics refers to society's sense of the right way of living our daily lives, and it has to therefore establish some rules, some principles, some values, and the most often concepts, as we've seen in the previous slides, and you'll hear a lot more about today: truth, honesty, fairness, and equity. So while ethics is a societal concern, it's of course of critical importance to the professions that serve the society. So in our case, in occupational health, we will be put at a higher level of understanding. Of course, we're talking about a principle of a multidisciplinary task, so I try to get a bunch of, South Africa has its fair share of organizations, and I'm quite sure I haven't covered all of them. But I want to take us back to the International Code of Ethics for Occupational Health Professionals. As I said, 32-page document, but it's summarized on, I think, page 12 in the following paragraphs, which I really would like to endorse and work with the group today. The purpose. So firstly, we have a purpose in occupational health, and that's really a very good base for any ethical discussion. And that purpose is to serve the health and social well-being of workers, not only individually as inpatient, but also collectively as a group. The practice of occupational health must be performed according to the highest professional standards, which implies we have to have some professional standards somewhere and the ethical principles. Occupational health professionals, however, as we've clearly heard from the public health viewpoint and from the thought of yourself being in society, we must also contribute to environmental and community health. So in fact, we cannot steer away from during a crisis that we have to take action. The duties, and often this is written up in our local guidelines, the duties of us as occupational health professionals is mainly to protect the life and the health of the worker, respect human dignity, and promote those highest ethical standards in policies and programs, which again infers that we must have them, they must be written. Integrity and professional conduct, impartiality, the protection of confidentiality of health data, which you've already heard of, and the privacy of workers and all of this. We are seen as experts, which we already said. We must enjoy full professional independence in the execution of our function. We must acquire and maintain our competence necessary for duties and acquire conditions which allow us to carry out our task according to the good practice. Now, if you use these 3 paragraphs, and just as a summary, you can write any contract with any client you have, and you can make sure that your ethical base is strong and will not differ when you have any crisis. As I've been talking quite a bit now, we clearly understand that there's ethics and then the yang or not. So what is ethics on the right-hand side? Yeah, again, I have the thumbs up and thumbs down. You can clearly be anything from at the bottom, ill-advised, to inappropriate, to unprofessional, to unethical, to unlawful. So clearly, when you get a question, you have to answer a question, you consider what a group of people are discussing, particularly in crisis times. Make sure that it's not one of those, that you're not being ill-advised. Also, ethics for us as occupational health professionals goes all the way back to Ramazini in the 1600s, where we already said that it's our job as medical people or occupational health professionals to secure good conditions for workers. It's the right for us to believe in the benefit and the relief, and therefore we have to understand the circumstances, and particularly if we go back to Dr. Kubeka's discussion, the social determinants of the workers who also live within a society, and we need to take cognizance of that. Ethics during a crisis isn't really different. I'm trying to contend that it shouldn't be, and we'll cover a quick few points about crisis ethics, about the whole discussion around obligations and duties, responsibility and accountability, communications during a crisis, and a concept of humanistic care. I believe, however, that the golden thread through all of this occupational health during a crisis is communications, and I will have added a lot of slides at the end of the presentation for additional information for people that would like to read up a bit more. So I found a counterpart in my own name in crisis communication theory, and for the fun of it, I just put it in. So Coombs, but it's not me, defines crisis as the perception of an unpredictable event that threatens important expectancies of stakeholders and can seriously impact an organization's performance and generate negative outcomes. A crisis can create threats to public safety, financial loss, and reputational loss. And these threats are interrelated, very similar to what we heard about public health. You can read more about this in Ethics in Crisis Management, and there is an organization called the Professional Crisis Management Association for just to better understand ethics in crisis. Here is somewhat slides from the Ethics in Crisis Management course. You can see where you can find it, and this is Mitrov, which has defined a 5-stage model for crisis management. Clearly, as an organization, as a doctor, as an occupational health profession, you have to have some sort of a signal detection, meaning you have to probe and understand if something's happening. Is the crisis coming? When is it coming? What is the damage containment? What does recovery mean? What does learning mean? And I think there's a positive feedback all the way back to signal detection. So clearly, as an occupational health professional, we have to consider what happens and if a crisis is going to happen. And then what are these ethical principles then related to our obligations and duties, our responsibility and accountability? And I'm not going to try and read through. I gave you a rather more thorough set of slides to read, but I'm not going to try and read just the things to you. But the whole basis of it is that our moral responsibility already goes back all the way to Aristotle and the philosophers, and saying that it's our ability to reason, our awareness of action and consequences, our willingness to act free from external compulsion that puts this obligation and duty into us as a society, and therefore it becomes more onerous in a professional manner. It's the readiness to be prepared to give explanations for our judgments, our intentions, our actions, and particularly in the professional context, accountability is about answering to our clients, our colleagues, and the other professions. And particularly in the multi-professional manner that we work daily in the workplaces. So responsibility is this ethical concept that we have morally based obligations, and even to the larger society for ethical moral codes and standards, and that us as professionals have a readiness to take our actions to be judged by others, to accept our responsibilities for errors and misjudgment, but to work on recognition of competence, conscientiousness, excellence, and wisdom. So there's a whole base of ethical background that we bring into a crisis, and it's really trying to find it already ahead of time instead of during the crisis to wanting to fix our ethical base. And in the case of communication, as I said, also in trying to find how do we communicate this ethical base that we already have. And I want to introduce a concept which is ethics of significant choice by Nielsen. And this is an important ethical principle that can be applied in crisis communication that involves the concept of significant choice. Because a crisis has this great potential for harm and disrupting our daily routines, the ethical concept of significant choices, individuals must be given enough information to make a reasoned decision. And of course, for organizations, and this is just some concept around organizations and their responsibilities in communication before, during, and after a crisis, is that they have to train people to monitor the crisis risk in the pre-crisis stage, in the emergency stage, to make sure that decisions can be made rapidly, and then post-crisis communication is that we can wrap up the crisis communication messages in the recovery process. There's more to read about that in later slides, but I think it's a very important concept of communication. Ethical principles then of humanistic care. This is another concept that I think is important for occupational health professionals, is that any crisis is going to create victims. And based on this care principle, the first priority in any crisis is to protect stakeholders from harm, not the reputation of the organization. We hear often about the dual loyalties between the company and the employee, or the patient or the worker, but I think there are multiple loyalties that we have to consider, having looked at our ethical base as individuals, and make sure. I'm going to end off with some practical aspects and checklists, and I won't necessarily read through all of them. In the slide set, you can have a look, because these are things that need to be used in a practical sense and not a concept. So we look at your objectives during your response in a crisis in occupational health, choice, misinformation, and that power balance we've already heard about. I'll share with you a short slide on the concept of VUCA, and then outcomes-based management for your ethics. So why ethics in crisis is always the question. What does it mean in practice? And is it about finding the truth, or is it about, as we say in the little cartoon, is it a junior, senior doctor, and then a spin doctor? Are we just trying to give fake news or change the ability not to do anything? So ICO, very clearly, we always have to go back to our occupational health principles to protect the life and the health of the worker, to respect human dignity, and to promote the highest ethical principles. So I go back to the practice. The practice should be question all again, omnem questionum. What is it? What is the question or request that I'm asking to respond to? This choice of who gets the ventilator, the choice of who comes to work or not, on what is that based? And of course, Aristotle already told us in the elements of circumstances, always ask the question, who, what, when, why, where, in what way, and why what means, or in the more modern terms, 5 W's and a how. And John Doherty has also said, if you wanted to make sure that you answered all those questions correct, are you sure that you're looking for truth? And truth always has to be defended or searched through with the 3 practical. Does it correspond to truth? Does it have a coherence in argument? And is there pragmatism to it that we can actually establish? Otherwise, we are just adding more uncertainty to it, which brings then adding to more uncertainty to it. We have to communicate appropriately. So crisis communication objective should be to provide accurate, timely information to all internal and external audiences, to demonstrate concern for safety of lives, to safeguard organizational facilities and assets, and to maintain a positive image, but in that order. Again, from Coombs, best practice for initial crisis response: be quick, be accurate, and be consistent. And then there's a whole list of somewhat more detail of that. Be quick and try to have an initial response within a first hour. Be accurate, checking your facts. Make sure that you have consistent messaging about what is happening. Make public safety priority number 1. Provide some expression for concern and sympathy for victims. Remember to include your employees and not just go externally. And then, as we've already heard, provide stress and trauma counseling for the people. Significant choice, I'm not going to go into it, but this is a very important thing, is making sure that people have the information, but that they can actually understand the information concerning their own well-being and make that informed decision. So misinformation is obviously an important issue that needs to be looked at, and some forms of communication, such as bias, ambiguity, emotional language, can distort or create unnecessary alarm, and I see we've all seen enough of that. And this uncertainty and crisis is most probably in organizations threefold. It's due to the lack of information or real data, due to the complexity of the information, or due to the quality of the information. Which brings us to a concept of we have to understand, from the perspective of the party sending the message, careful consideration of the audience's ability to comprehend and act on that information, and make it equally important what you say and what people receive, that they can act on it. And there's a whole set of literature called disaster literacy about an individual's ability to read and understand the information to make informed decisions, which would be important for you to learn more about, but not for today's discussion necessarily. However, I will want to leave you with the fact that whether you are part of this organizational response in a company in passing on communication, you have the power to control the communication, and therefore you're obliged to use this power quite ethically. And very often the OHP is the person that can bring ethics into this crisis communication. Which brings me to the concept of VUCA. You can go look it up and read it up, but it's just the whole world is becoming more volatile, more uncertain, more complex, and more ambiguous. And this is clearly what happens during a crisis management. And there are a lot of interesting tools to address each one of those. And I do not, again, want to have a discussion around that. So outcome lists, it's very important, I think, for practitioners to practice proper ethics, and therefore having an outcome list of what we would like to go get during such a crisis to demonstrate. And here's a short list about our communications checklist to demonstrate respect for people affected by the risk management decisions, involve all parties in that stake, include decision-making process with a broad range of factors that include risk and concern and outrage, to use many communication channels, to adhere to highest ethical standards and hold people professionally and ethically accountable, and strive for beneficial outcomes. Purely from an outcome list after the crisis or before, you can think we want to have early detections of signals so we can have appropriate responses. We want to contain the injuries and deaths within our own sphere where we do have a potential. We want to have critical business continue particularly in industries, healthcare, food, and all of those critical places. We want to learn, we want to check our policies and procedures, keep the reputation of the organization intact, allocate proper and appropriate resources, and that the evidence that we have is timely and the accurate decisions are grounded in facts, and it all really, follows into the same question, that we can make ethical decisions, we can accept responsibility during time of crisis, and we can provide an ethical basis for facilitation of humanitarian care. Thank you very much for the opportunity.
Thank you very much to Dr. Marie Coombs, having dealt there with the topic, an overview of ethics in occupational health practice and outbreaks. And I now have the pleasure of inviting Dr. Frank Fox to deal with the topic COVID-19 related ethical issues specific to occupational health practice. We're looking at the practical implications, both from a global to local perspectives, and then issues like the roles and the responsibilities, who does what in terms of different roles, including laboratory, occupational medical practitioners, occupational health and nursing practitioners, human resource role players, safety practitioners, as well as the occupational health and safety committees, which I think is also coming to a specific focus recently. So welcome, thank you very much, Dr. Fox, for joining us and sharing your experience, knowledge, and guidance for us today. So if you could just share your presentation, and while Dr. Fox is doing that, a brief introduction. Dr. Frank Fox is an occupational medicine specialist in private practice. Dr. Fox has been working in occupational medicine since 1985. He has extensive experience in the mining, forest products, pulp and paper industries. He retired from being global head of occupational health for the Anglo-American Corporation in 2015 and went to work in occupational medicine in a private practice in Ireland. He returned to South Africa in 2019. So thank you, Dr. Fox, for joining us. I see you have your slide shared. I hand over to you. You may have to unmute your microphone. I'm not sure if you are unmuted. Dr. Fox, are you there?
Can you hear me?
Yes.
I don't seem to be muted. Oh, at last.
Yes, yes. There you go. I can hear you. Thank you very much. Your slides are also clear and your audio is very good. Please proceed. Thank you.
So thank you very much for asking me to speak. After the last two speakers, I doubt I'm actually going to be able to add an awful lot to what has been said. But nevertheless, let's have a go. I don't consider myself an expert on ethics, so what follows are really my views and my opinion, and I must note that I don't represent any particular organization. I am the author of the SASOM guideline on ethics, and I've delivered several lectures at NIOH courses on the subject. But having said that, ethics is a constantly changing field, even though it may seem constant. Previous speakers have said this, but ethics are always a personal choice, and they're a way of life in a way. Every decision we make should be considered on the basis of the ethics of our profession, and they need to become an unconscious decision in how we work. Having said that, this COVID-19 pandemic has given us a lot of dilemmas, and it's certainly clouded thinking around many decisions that we previously didn't worry about in occupational health. The one thing that seems to have come through is that we seem to have forgotten that this is not the first community-acquired infectious disease with fatal consequences at that, that can be passed on in the workplace. But perhaps the scale of and ease of infection and the unknowns have contributed to some of the difficulties that we are presently facing. The questions that are coming up from time to time are all around issues that we've dealt with in the past and seemingly with ease. I'm not going to answer all those questions, and I'm probably going to leave you with some. So let's get into this. These principles have been mentioned and they were there right at the beginning, but I think it's a useful place for me to start in terms of the application of these 4 basic principles of medical ethics, which are known as the Georgetown mantra. Autonomy is really about personal choice. It's about the ability of the individual to make personal choices. And since dual loyalty has been mentioned, it's also about the ability of other parties in any situation to make their choices as well. In typical medical ethics or in traditional medical ethics, it comes down to informed consent. Beneficence obviously is doing good, non-maleficence doing no harm, and then distributed justice is really around fairness. And I think I should remind us that even though pandemics create unusual times when we might think that traditional views of ethics are challenged, it's actually during these times when careful consideration of ethics becomes most important. Whoops, I think I've flicked through these rather rapidly, sorry. Mouse troubles, technical challenges. Okay, so let's just go to ethics and occupational health. Now, although we typically talk about patients in occupational medicine and occupational health, there is in fact this problem that we seldom actually have a patient. We have a client. We may work for an employer. We may be engaged by an employer to perform occupational health functions. And the people that we examine on behalf of the employer are in fact not our patients. So there's typically no doctor-patient relationship. And in most occupational health practice, we're careful not to establish a doctor-patient relationship. If we do end up in the situation of providing primary care or of being in a situation where we do develop a doctor-patient relationship, we have to be very careful to separate the roles of being a doctor from being the occupational health practitioner. And that's not very easy at all. What this COVID-19 pandemic has done is blur this line, and many OMPs are finding themselves stepping over. They're finding themselves in a situation where they're having to look after people who may well be in a company created and run quarantine or isolation facilities. They're looking after people's medical conditions, their contact tracing within the workplace. And this line between there being no doctor-patient relationship and one where there is has become extremely grey. And going back to this whole dual loyalty situation, it's always a challenge in occupational health. And I think it's important to recognize it here as it's the cause of many of the issues. Part of the ethical practice is in maintaining confidentiality and competence. Sorry, competence, not confidentiality. And in this new and rapidly changing scenario, we're all being asked questions that are either on the edge of our competence or are about issues where we have to become competent. And we need to be careful that we do this. We've all had to become familiar with the laws regarding occupational health practice, but then these suddenly get moved around when we think about how the Disaster Management Act and its regulations have changed that. underlying all ethics, there is the law, and we sometimes find it very difficult to comply with the law in an ethical manner, but we actually absolutely have to comply with what the legal requirements are. I've listed all those laws there. I'm not going to go into them one by one, but I think we need to remember that every person in the country has constitutional rights, and Dr. Kubeka mentioned that in her presentation right at the beginning. She was also careful to mention the POPI Act, which does complicate the whole question of sharing information. So on to some issues, and I suspect I'm going to give you some time back in this. The rapid and sometimes confusing and conflicting changes in the law have not made things easy. In 1 minute, we are quarantining people for 14 days, then suddenly we're quarantining them for 10. We have the whole question of the infringement on people's personal rights, and there are obviously legal justifications for this. And in the field of occupational health, we have this peculiar situation of different acts covering general industry and the mines in terms of health and safety, and the different departments that have tried to interpret the disaster management regulations have come up with, as one would expect, different interpretations. The regulators have not always been able to align their thinking, and we've ended up with different approaches within the Department of Mineral Resources and the Department of Labour and Employment. There's also the question of guidelines. Guidelines have been issued by the National Department of Health, by the National Laboratory Services, and by NIOH. And there have been various semi-panicky notes that have come around as to how people comply with them. And we have to ask ourselves, are guidelines in fact law? Dr. Coombs alluded to the false information that's going around, and we've had to manage this infodemic, as it's been termed. There have been all sorts of claims that we've all, as occupational medical practitioners, had to deal with. You know, one of them that went around recently was, we're not having our temperatures taken because you're pointing this infrared thing at my forehead and you're damaging my brain. And people get some strange ideas around these things. And unless you are quick on your feet and can say, but you know, a thermometer actually doesn't send out anything. It is a camera and it picks up heat. It's not about sending anything into your head. And that's just one of the little things. Also, we've had this climate of people jumping on the bandwagon and taking advantage of the situation in terms of what they can sell and what they can convince companies to buy. And there's a lot of snake oil out there. I mean, one of the things that went around early in the pandemic was the idea of a disinfection tunnel, and some very prominent organizations rushed out and bought these things, only to find that in due course the WHO came out and said these things aren't a good idea, and that was backed by our own Department of Health subsequently. So they then ended up with potentially expensive pieces of equipment that weren't really any good to them. Similarly, a lot of suppliers have rushed around selling disinfection solutions and all sorts of things that companies have, in their panicky situations, have gone out and bought. And the occupational health practitioner has been in the firing line in terms of being asked to give advice on whether these things are effective and do they work. and should the company buy them. Testing is another particular issue that comes up from time to time, and there are some questionable practices around this. Unfortunately, some of these seem to have been supported by doctors. I mean, the questions of mass testing, for example. Can we mass test? Should we mass test? What are the benefits of mass testing? And one has to take a very careful look at these things. One has to have some knowledge about what the sensitivity and specificity, and with that, the positive predictive value of a test is. What the basis of the test is, because you can spend an awful lot of money on testing. And I know of one major organization that tested 1,000 employees on a mass testing basis at 800 Rand a test, which is a significant amount of money to be spent only to pick up 2 positive cases. Now that really was a waste of money, and if they'd taken sensible medical advice, they'd have realized that the validity of the test was only for the day on which it was taken. So a week later, it was completely irrelevant. So the whole thing around testing of who, when, why, and how, whether you can in fact force people to have a test or not, and that cuts right across the issue of autonomy. My answer to that is no, you can't, not without informed consent. But others may have different views. A second thing around testing is that there are some that are saying you can't come to work unless you can produce evidence of a negative PCR test. And the whole problem around PCR testing, it's quite low sensitivity, and the fact that it's really only valid on the day the swab is taken makes you wonder about the ethics of those things. The other issue is around the number of tests that we've been doing and the ethics of significant numbers of tests on the basis of quite weak evidence, which have removed tests from a resource-constrained environment and perhaps taken them away from people who are more deserving. And there's the whole ethical question of that. And I think occupational health practitioners or occupational medical practitioners have a responsibility to advise employers against unnecessary testing in resource-constrained times. There's also been the question of laboratories who have been asked to undertake mass testing and have been quite happy to assist. And one wonders about the ethics of that. Testing of asymptomatic people. Should we be doing this? I mean, actually, it can only be done with informed consent from the person. And in my opinion, it's unethical to do otherwise. In terms of sharing of information, and this is a common question, there are the issues of confidentiality. What about statutory reporting, and what about contact tracing? So, you know, one has to think about the question of which tests you're doing, and the suppliers that were very quick to start pushing unverified test kits in the absence of approval from SAPRA, something we still have to guard against. And I just need to re-emphasize, we need to be sure of the value of antibody tests before we start rolling them out as immunity passports. There's still a lot of uncertainty as to how long antibodies last and whether they are in fact neutralizing antibodies. So against that background, we now start sharing information which cuts across the confidentiality issues and the POPI Act. There are often questions about whether employers can demand to know why an individual is off sick, whether they've had a a test for COVID-19 and what that result is? And the answer is, in general, no, they're not entitled to know what the diagnosis is, unless there is a situation where they have to protect the health of the rest of the population, the rest of the workforce. And then it comes down to a contact tracing issue. Now, the person who takes that COVID-19 test is required by law to report that positive result to the Department of Health. And I would say that it would be responsible to report that to an occupational medical practitioner in a company, if there is one there, so that contact tracing can be undertaken. The OMP can then make a decision as to, or investigate and make a decision as to whether contact tracing is in fact necessary within the workplace, and only then would this information be released to the employer, because you're going to have to contact other people who were in contact with that individual. There are obviously very specific legal allowances for this, and the utilitarian view of the protection of third parties is most important in this particular thing. Against all of this, you end up with pressure from employers, regulators, and the unions, which then clouds the whole issue. And again, I think Dr. Coombs alluded to this in his talk. There was a Dutch psychologist, Hofstede, who came up with the concept of a power distance index. And that really is around the ability of the weaker party in a situation to make rational decisions. Most of that research was conducted around how pilots make errors when ratty air traffic controllers shout at them. But it is very important in this as well, and I'll go further into this when we talk about vulnerable employees. This one's a particularly thorny one, because here we are, we're trying to protect an individual who is at risk of severe COVID complications. That person's at no greater risk, in fact, of catching the infection. But if they get it, their consequences may be greater. And there are lots of panicky situations where employees have perhaps been unfairly denied access to the work. Now, our Constitution gives us a right to employment and to make a living, to look after ourselves. And there are lots of people who are potentially being denied access to that because a proper risk assessment hasn't been done. And I'd like to quote from the Faculty of Occupational Medicine in the UK, because this particular problem has been taxing everybody around the world. And if you look at the way things have been going, what we're facing here in South Africa is exactly the same as they're facing in the United States, and they've been facing in every other country. And if you listen to the news, you'll see that they're all facing the issues of lockdown and the economic impacts and the infringements on people's personal freedoms and so on. So it's we're not alone in this particular thing. Anyway, to go back to it, and I'll quote this: an individual's health risk factors, should they be exposed to or contract COVID-19, is a relevant data point when making occupational health recommendations. But this may only be used in the context of a wider assessment of that person's personal and employment circumstances. A person working in a public-facing role may be at significantly lower risk than another in a similar role, personal factors aside, if appropriate risk mitigation strategies are put in place for them in the workplace. As part of managing the health and safety of any work activity, one must control the risk in the workplace. To do this, one needs to think about what might cause harm to people and decide on reasonable steps to prevent that harm. This is known as risk assessment, and it is something that is required by law, and particularly in our health and safety law. So when we think about vulnerable people, we need to think about the freedom of choice of the individual to work. That's the autonomy part. The same freedom of choice of the employer to restrict or allow that person access to the workplace. And that's around the protection of other workers and the protection of the reputation of the organization. But on top of that, you have pressure from regulators, inspectors, and the unions, where there's panic if somebody is in fact infected in the workplace, and then there's the concern about what if somebody dies. All of that goes to this principle of power distance index. From the occupational health practitioner's point of view, it's absolutely essential to consider both sides. And at the end of the day, this is not about fitness for work. This is about a person who is vulnerable. And there's nothing new in that. We've often had to deal with people who have vulnerabilities. And then the decision around employment comes down to a recommendation to the employer to say, this person is fit for work with certain restrictions. And it's up to the employer to make the call as to whether those restrictions can in fact be accommodated. At the bottom of this, there's no need to exclude a vulnerable worker if the risk in the workplace is in fact low. Now that's perhaps a simplistic view of it, but it is something that we all need to think about quite carefully in this current time. For work issues, it's still a very valid concept. Employees with comorbidities or being above a certain age, they're not unfit for work, but it may be unsafe for them to be there. And we need to do that risk assessment to give them an opportunity to be at work. Obviously, if employees don't want to be at work because they're worried about this, then that's another situation where the employee has to be carefully counseled, and they must make an informed decision as to what their options are. And sometimes those options involve talking to the HR people in this, because it's not the doctor's call at the end of the day. Again, this is nothing we haven't faced before in terms of dealing with these things. The question of returning to work after a positive test or an illness is simply a question of fitness for work, and obviously we all have to maintain our competence and be aware of the issues that arise having had COVID. Some issues around quarantine and isolation. Only the government can actually forcefully quarantine somebody, and where we've had to take on the role of government in assisting by providing quarantine facilities in the private sector, we have in fact run across this particular issue where we've had to say, look, can you self-isolate at home, or can you go into a quarantine or an isolation facility provided by the company? And the ethical issues around whether or not you can push people into these things have been taxing a lot of people. In the mining industry, at the beginning of the pandemic, there was a situation where one of the mines had to rapidly quarantine over 100 people. And within 24 hours, a number of those people had broken out, for want of a better description. Another ethical issue that is coming up is around the care of employees. And we also need to think about their families, because if somebody is infected or is quarantined, one has to consider the families in this. And a second question that has arisen around that is what is the risk of an employee who has a partner who's a healthcare worker, for example. So the partner is in a high-risk occupation, and my employee is coming to work, and I think they're a higher risk because they might be a primary contact of somebody who is in a high-risk job. And we have to face these things and take a fair decision around these things. The last concern that I'd like to just look at is the question of whether this is an occupational or a community-acquired infection. And it's my view, and again I stress it's my view, that this is actually a community-acquired infection that can be acquired in the workplace. It is a work-related condition specifically, and maybe an occupational condition for healthcare workers who are specifically exposed to this in their working environment. And in that sense, it's no different from any other infectious disease like tuberculosis, which a healthcare worker can contract. But if we go too far down the road of saying this is an occupational disease rather than a work-related disease, then every time there's a flu outbreak or any other infectious disease that someone can get at work, we run the risk of having a similar situation of excluding people from work unfairly. So in conclusion, I think there are lots of questions. I haven't answered half of them, but I think the answers in terms of how we address this, these things from an ethical point of view is in looking at the legal requirements and asking ourselves how we can obey those legal issues in an ethical manner, and we apply those four ethical tenets. The big thing is that if there's a real ethical dilemma, you're seldom going to solve it on your own, and consult a colleague. Two heads are always better than one, sometimes more. Consult a senior colleague if you can, but at the end of the day, remember the ultimate decision is yours. And then one last thing as a piece of advice for occupational medical people is that it's important that you stay within your competence and your scope of practice. Too often, because we are the first point of call for workers, we end up hearing all the problems related to pay, related to the fact that things haven't been reported, the fact that of working conditions. And yes, these may well affect the person's mental state of health. They are not within the gift of the occupational medical practitioner to solve. And we should stay out of the HR area. We should stay away from legal issues and stay within our own areas of competence. And that means if you have somebody who is unfit for work, you may not be able to solve the problem that the employer isn't going to pay them if they're unfit for work. Somebody who needs to go into quarantine because they have this, they are a primary contact, the fact that the employer may not pay them is again outside the scope of the occupational medical practitioner. We have to act on the medical side of things and stay out of the other areas. That doesn't mean we can't try and influence the people involved in that area, but we cannot make decisions on that basis for the individual worker. And I'd like to leave it at that. I said I'd give you some time back, but I haven't really. Sorry about that.
Thank you very much, I think, Dr. Fox. It was certainly worthwhile. We are slightly over, but not a big crisis. If you could unshare your screen, that would be much appreciated. Thanks. I now need to introduce Dr. Tabani Kwanyana, who's going to deal with the COVID-19 medical legal considerations in occupational health practice in South Africa. So welcome. Thank you very much, Dr. Kwanyana, for making the time and effort to contribute your experience, knowledge, and views with our attendees, our audience. As part of a brief introduction, whilst Dr. Kwanyana gets the PowerPoint presentation ready to share with us, Dr. Kwananyana, that's Tamani. He's a medical officer and lead consultant at Kwananyana Consulting, qualified medical practitioner with a master's in medical law and ethics, an interest in medical legal, socio-political, and socio-medical issues. Qualifications includes an MPCHB, I think this is a diploma in occupational medicine and health, probably the postgraduate diploma in occupational medicine and health, and an MPhil in medical law and ethics, a PhD candidate in medical law and ethics. Although I'm not sure, you can perhaps add, Tabani, with regard to which academic institution that would be. Experience in general medicine, aviation, risk insurance, and occupational medicine. Thank you very much for taking the time. If you could share your presentation now with us. And oh, you have unmuted. Great. Thank you.
Thank you very much, and good afternoon, everybody. It does say the host disabled participant in the screen sharing. So I don't know.
Okay, one moment.
Yes.
Yes, I'll ask my colleague Glenn in the IT department just to assist us there with regard to screen sharing for you.
It's not that you can share.
Go ahead. Okay. Thank you very much, Glenn. Go ahead.
Okay. Okay, is it sharing? I'm not sure if...
Yes, it is sharing. You just need to maximize your slide. At the moment, we can see both the smaller versions on the left as well as your notes at the bottom and your slide. That's perfect. That's perfect.
Oh,
thank you.
There we go.
Please proceed.
Okay, thank you very much. The question you asked, I've done my master's MPhil in medical law and ethics with the University of Pretoria, and I'm currently doing my PhD also with the University of Pretoria. Yeah. So
thank you.
Basically, yes, thank you. I think most speakers have talked about a lot of things in terms of ethics and medical legal aspects. So, which I think this is quite suited in terms of what they've covered, because what I've prepared here is really just to kind of get conversations going around certain issues about the medical legal aspects during this time. So, just briefly on the introduction, things I would like to look at. Obviously, when the pandemic is been declared. You have a lot of public health measures that we want to look at and see what are the implications of those in terms of the medical officers and nurses and perhaps all other healthcare workers. And then I'll just base as well on the legislations as to what changes during a national disaster, for instance, as opposed to any other circumstance. And then a brief in terms of some of the limitations in terms of Constitution and the Bill of Rights. And I think they've also talked a lot, other speakers, on the occupational and other labor related matters, and then medical legal issues in terms of what things that can go wrong, and then a brief on the ethics again, as all other speakers have also spoke about. So basically, the declaring of a pandemic, this is driven by the World Health Organization, and based on the circumstances on how fast the disease is spreading and how many countries it is affecting, then the countries that subscribe to the World Health Organization are guided by this to say what measures they all need to put in place once the disease has been declared a pandemic. So in South Africa, for instance, we watched the events as they unfolded, and the government then declared a state of national disaster, which is governed by a National Disaster Act as well, slightly different from a state of emergency which is more serious, where the country is a threat for wars, for instance. So a state of national disaster was declared, and that in a declaration of a state of national disaster invoked certain limitations, such as the limitations that are mentioned in the section 36 of the Constitution. So you will know that constitutionally, we have a certain rights, the Bill of Rights, which talks about a whole lot of things, such as freedom to choose, freedom of association, freedom to of movement and all that. But with that Constitution and the Bill of Rights, there's a section that talks about limitations, and these limitations include circumstances such as when a state of emergency or state of national disaster has been declared. And again, briefly on the implications, which you of course have seen, and people have challenged it also even in court. You get people that are subjected to such compulsory quarantine, for instance, and even forced isolations. And I mean, speakers have talked about what happens if somebody refuses to be tested, refuses to be isolated and all that. So during a state of national disaster, then those limitations into rights comes into place, which means you could be forced into isolate. Again, if it's seen as being fair and as being in the public interest, for instance. The other possible problem or implication there is that the government might also be forced to disclose your personal information. Ordinarily, you would have a right to your personal information and who it is shared with, but under the state of national disaster, that information could actually be shared by the government, and your privacy might be compromised. And broadly also, there might be a whole lot of human rights violations. As we have seen, the military get deployed, the police get deployed into the streets and all that, which means that in terms of a spectrum of human rights, there could be a whole lot of rights that get violated during the state of national disaster. Okay, so I've touched briefly on the Constitution and the Bill of Rights, and if you look at these, it states categorically that all citizens, all persons have the right to their confidentiality and the right to privacy, right to personal, particularly medical information, and the right to choose, which means I have a right to choose where I want to go for my health care. I have a right to choose as to which facility I go to and all that. And all these can be affected during a state of disaster. I see somebody raise their hand. I don't know if we take questions during the session.
No, we're not taking questions during the session. We're asking our attendees to just type their questions in the Q&A box, and replies will be posted for them there. That's not a good idea for us to proceed with questions with a large number of attendees we have. Please proceed. I might raise a question. I'll look for that person's question and raise it once you're done.
Okay, that's fine. Thank you. Okay, so and the biggest thing again has been the right of freedom, right to freedom of movement, and other rights. It's a wide range. People's dignity could be affected. The access to healthcare when you're dealing with the overloaded health systems could be affected. So these are some of these just basic rights, and the issue about justice, in particular distributional justice, where there might be now limited resources, you might be turned back, you might not have access to certain services because the system is overloaded. Those are some of the limitations that will come with this state of national disaster, particularly if there's a pandemic. Okay, so there is also a few implications in terms of occupational and labor issues. The main thing with occupational is just the health and safety aspect. And we're going to again talk about issues such as now have you got enough PPE, and what should happen if you don't have enough PPE, and people have covered that as well. But it's really just the soft aspects here that we're going to talk about to say, do you have a right to refuse to treat the patient because you don't have the PPE, and what could be the consequences of that in terms of the labor laws. And again, people can be even exposed to forced work or even limitations of their leave, which means during a pandemic or during a state of national disaster, particularly for healthcare workers, you could be subjected to limitations such as you cannot take leave during that period, which most people might see as a violation of their own labor rights. And also you must be forced to work, you might be forced to work or even put on extra hours. And there also is a huge risk of job losses, including dismissals, particularly as people are concerned about their own health and exposure. They might also maybe slack in terms of the work that they are doing, which might expose them to dismissals. And also some of them might blatantly refuse particular orders to seniors, and that can be seen as insubordination. But it could be because of their concern about their health. So it's about all those balances as to what it could be the implications during this time, and also maybe what courts consider. Should there be a case, a CCMA case, or other disputes, for instance? Okay, so just in terms of the health and safety for healthcare workers, we do have an NIOH Act which prescribe the general duties of the employer. For instance, in the section 8.1, where it says every employer shall provide and maintain as far as is reasonably practicable. And again, there's a lot of keywords that are in this statement, which is also something that can be tested as to whether was the situation reasonable, was it practicable? So, because it does protect employers somehow, where it is found that it is maybe reasonably impracticable for them to provide that safe environment. So it says every employer shall provide and maintain, as far as is reasonably practicable, a working environment that is safe and without risk to the health of his employees. And then we know, for instance, just that last statement alone to say, if we say without risk, do we mean zero risk, or really that we mean that it must be mitigated and minimized as much as possible, as we know that risk is inherent. But as a healthcare worker as well, the risk tends to be inherent, and there has been calls for some of the work that we do during this time to be classified as dangerous work such. But those are all the implications that we have to look at to say, what are the duties of the employer, and what happens if the employer is not adhering to these in the first instance, because there should be at least a balance of what the employer offers and how reasonable that is versus to say resources. And in our case, for instance, most healthcare workers where there's government resources that are at stake, and looking at also all the matters of distributional justice as to whether is it fair perhaps to put all resources to, for instance, PPE, and compromise the health of the patients as well. So that's a balance that has to be looked at, and the courts look at those things as well. The other aspect of health and safety in the NIOH Act is that duty to inform. So the employers also have a duty to inform as far as also reasonably practicable, and make all their employees aware of the hazards that are associated with their work, which means if you are exposed to COVID, or maybe there's an outbreak at the hospital or where you work, the employer has to inform you to say there's an outbreak and this is how dangerous it is, should you be not aware of that. So these are just in the general duties. Okay, and you also as a healthcare worker have a duty to protect your own health, because you can't leave everything to the employer to say, well, you need to protect me, which means you also have to stand for yourself to say, I have a duty to protect my own health, especially during this time. And which means you must take the current public health advice and take necessary precautions. And also the question here is, what do you do if you want to protect your health, but at the same time you have to put your life in the front line and maybe most other circumstances without protective equipment. Okay, so the other quick one, which I will not dwell too much on, is an issue of compensation. To say, can healthcare workers feel that they actually can be compensated? Should they be affected by COVID? And the categories I've put in here is really where the Ministry of Labor has come up with to say under which circumstances they can actually be able to meet you halfway, which means if you're temporarily totally disabled, you actually could be taken care of. Or if you're a person under investigation, so this is now in terms of the leave, the type of leave that you take. And most places have made it possible for you to take leave without eating into your annual leave, for instance. And then if you become a confirmed case, most employers have been able to, especially in the health sector, have been able to give you time out, which means you could just be given time for quarantine and without tapping into your ordinary sick leave. But obviously there could be other circumstances where you become permanently disabled. And also, should you be needing medical care and maybe you are not treated in a public facility, the employer has an obligation also to make sure that they pay for your medical bills. But obviously that also can be weighed in terms of why maybe you couldn't be treated at a public hospital. But this becomes an issue just when maybe a person uses their own medical aid without getting an authorization first. Then it ends up an issue to say, how do you then claim that? Because this is more paying for health services rather than money that comes to you as such. And then the death benefit also to say they can take care of your funeral as well, and then what are the lump sums that get paid after you die. Okay, so just on the medical legal risks, because during this time then you get exposed to a lot of risks medical legally, which pose a challenge in that you actually could be sued. There could be a case of medical malpractice against you. And we know these as facts to say when there's a pandemic and when there's an overloaded healthcare system, especially also when you're dealing with a disease that has a potential to also infect healthcare workers, these are potential challenging circumstances that can result. First, you could lower standards of care. And we'll talk briefly about that as to what it means in that now, what would have been a generally accepted standard of care during the times of pandemic that can be lowered, which means there's a potential risk there that somebody could claim that the standard of care was low and maybe then it risks them, whether it results into disability or personal injury or some form of claimable problem there. And we also know that patients can be neglected. We've had circumstances where people are treated under the tents, or maybe they are placed somewhere and they are forgotten and they die in that circumstance and all that, because there's high numbers, shortage of staff and all that. And the patient neglect is also a serious consequence in terms of people being sued, especially the state, because there's a potential there for somebody to say, I was left there to die, I was left there to be disabled, and from them or their families, then there's another huge risk. And the other big issue also, which we're going to talk about, is that possibility of departing from the established procedures to care for patients, which means if a patient comes into a hospital or medical emergencies, or maybe to the clinic, there might be a deviation from what used to be established protocols, which might result in delays of care, which might result in certain procedures not being done. Some of the procedures might be life-saving because then everyone is thinking about COVID infection and worried about it. And the other softer parts is where there could be breaches of confidentiality and other rights such as privacy, where now people are putting into common areas and their information needs to be shared with the NICD, needs to be shared with the laboratories, needs to be shared with the researchers, and maybe with the media as well. So that might be a breach. And then also these other prejudices and the human rights violations and abuses, which is also a broader concept, but it could mean a whole lot of things, such as patients being assaulted, such as patients being forced into maybe certain procedures that maybe they have not given informed consent and all those things. Okay, so just on those risks, we also know that as part of the World Health Organization declaring this a pandemic, then there was a sudden pressure on all governments, all states, for instance, to now mobilize resources, which means it is possible for people that maybe had not worked in a medical emergency or in a medical ward for a long time, and now they might be roped in to say, you now have to come in and assist. You might bring in people that are retired to say, come in and assist, and all those. So they have to look at what are the consequences of working outside your usual field of practice, because if something goes wrong in there, you actually may not be regarded as an expert or having enough experience to be practicing in that area. And also, I mean, you have a national call where government calls for everybody to come and assist, all healthcare workers, retired, volunteers, and all those things, to say, what are the implications of that should something go wrong? Okay, so in terms of the possible medical litigation cases, the main one could just be professional misconduct, which is also broader. It could be that maybe healthcare workers start not giving proper treatment to patients. Maybe they might be avoiding and there might be gross negligence or neglect. And also the issue of just negligence, where maybe just wrong procedures, wrong things, wrong medications are given to the patients, causing injuries and all that. And also there could be claims relating to the loss of life, where people die either due to neglect, either due to other circumstances there, to say maybe the certain procedure or life-saving operation was not performed because now we were worried that the patient might have COVID, because the turnaround time when you maybe get tested at the hospital before you go into the theater for a procedure, it might take a long while, and perhaps also personal injuries. And then there could also be claims for poor standards of care, as I had mentioned earlier. And some people could also claim in terms of discrimination, to say they were discriminated against, or maybe certain injustices or prejudices. Particularly, people could say they were discriminated because of their age. For instance, if you talk about dilemmas where now you must decide who gets to be ventilated, who doesn't get to be ventilated, who gets to be resuscitated, who doesn't get. And there could also be a racial discrimination. Again, when there's a competition for resources, some of the social ills and injustices also have a high risk to be at play. And then there's another potential area for litigation. And then just generally all other human rights violations that a person might feel that whatever way they might feel violated during this time, to say, I have freedom, we live in a democracy, you cannot do this to me. You cannot just force me into accepting a certain procedure that needs to be done, or accepting a test, or forced isolation, or forced quarantine, and all that. Those are things that people can take you to court for. Okay, just if you look at what courts obviously look at, if there's maybe a professional negligence case and the standard of care, it is important for all of us to understand how claims and the negligence can arise, and obviously for you to know what this description of that is. And of note or of importance there is that reasonability test, which looks at whether was it within reason, was it reasonable, whatever the circumstance had been there, and whether was it just a gross negligence on the healthcare workers' part? Because those are the things that the courts look at. So it's quite important for us to say, even if it's during this pandemic and we know that the standards of care can be lowered, but again, you can still be assessed in terms of whether the care that you provided, was it reasonable or was totally unreasonable? Okay, so, and then there will be certain things that maybe are like obvious in terms of dilemmas, medical legal issues that can be challenged, and there will be the others that are not so obvious. For instance, the common things that we faced with is deciding on who needs to be ventilated, who needs to have an ICU care when the demand exceeds our resources. And in other rare circumstances, some patients have to be removed from the ventilators and put in certain other patients on those ventilators. And you could also look there whether is that not now becoming an unlawful killing or some form of euthanasia when somebody is removed. And again, those things can be tested as to whether was there a futile medical care that they were receiving, or they had an opportunity to leave. Maybe they were just removed prematurely, and there's another potential area for lawsuits. And I mean, the issue about resuscitations and do not resuscitate, particularly here, because now if you drop and die or you drop and collapse on the floor now, people are going to be skeptical in terms of giving you a resuscitation, particularly because, sorry, there was an interruption there. I think somebody's sneezing. It might help if they mute the mic. Yeah. Okay, so I was saying that in terms of resuscitations, for instance, nowadays, if you drop and die, people are going to be skeptical in doing chest compressions, for instance. And it might not be enough time for you to decide whether, okay, does this person have COVID and not COVID? Because resuscitation, for instance, is now been labeled as a high-risk procedure, which means there's a high risk for people to contract COVID during a resuscitation. So it is possible, and it is easier for maybe certain healthcare workers to say, if somebody needs resuscitation, we will not resuscitate until we know their COVID results, which has a potential to cause disputes. Okay, then you have the not so obvious issues such as deviation from a proven effective medical treatment methods that were perhaps applied in the pre-COVID times. For instance, you could have somebody maybe comes into medical emergencies and they are a patient with COPD and they require nebulization. And nebulization now has been categorized as a high-risk procedure that has got a risk to spread COVID. Or maybe they need intubation, or maybe they need non-invasive ventilation. So which means now that might be halted until the COVID result is known, which means the person has a risk of dying while still waiting for the COVID test, when they could benefit from widely accessible medication, which needs to be administered through nebulizations, which maybe could be life-saving. So that deviation has a high risk of exposing us to being sued, because now you cannot have a mild COPD dying in a medical emergency just because they couldn't get the COVID swab, they couldn't get the nebulization. And then also the other limitations or other problems has become issues of failure to transfer to appropriate facility of care, because maybe this referral hospital no longer takes the patients during the time of COVID, or whatever might be the circumstance, to say, now you must take care of a patient for longer and maybe risk them being taken care of in a facility that is not appropriate for that care. And the other problem becomes the mixing of patients in the PUI sections where patients are being tested. So I could come in and I was perhaps negative or tested negative, but now you would have exposed me to other patients that might come out and test positive. The question is whether could I claim that you actually exposed me, and that's why now I've got COVID and I've died from it, because of maybe there were no isolations for people that are being investigated for COVID. And the other thorny issue is where people are infected at the healthcare facility or even by the healthcare workers. To say if a nurse or a doctor contracts COVID and pass it to patients, do patients have a leg to stand on to say, I actually got infected by the doctor, if they can prove it, and whether that can be a claimable circumstance. Okay, so, and obviously that will bring in the issue of whether do you get any immunity from liability during a national state of disaster or during a pandemic and all that, and whether the lawsuits and the courts whether do consider those aspects. And the principles in there is that the courts will look at the good faith principle to say a good Samaritan, somebody who was intending to help with no harm intended, and obviously considering their scope of practice and their expertise and all that, and whether they've worked in that circumstance or not, those are things that they will consider. And the other circumstances, the courts also know that when you're providing care under difficult circumstances, such as having to be careful about, I mean, already the physical examinations are limited because of COVID and the risk of exposure. So courts look at those to say, do we have to make that balance and make a decision where it was not just pure negligence, but it was working under the difficult circumstances under the pandemic. And then also they look at where maybe these were volunteers that had responded to the government's call to come and assist. It would have been retired people who may not be familiar with what is the latest in terms of medical practices. And again, they'll still look at that and see how much out of your scope of practice you went. And then there's other concept which is called vicarious liability, where your employer actually can maybe just cover you to say you came in to help, which means if there's any liability that or there's any claim, then we'll assume protection for you in that circumstance. But in most circumstances, even with all that is above that is mentioned there, for gross negligence, you might still be left on your own if all what you did was grossly negligent and maybe outside your scope of practice, totally unreasonable, again, based on the reasonability test, which means you could still be held accountable. And we cannot assume that because it's COVID times, you cannot be charged with the gross negligence and maybe face the music in terms of that. Okay, so which means then almost coming towards the end, there are guides, guidances, and in terms of core ethical values and standards for good practice. And these are the cornerstones of all that as healthcare workers we should be always thinking about and be considering when giving care, because these are things that will be looked at in court should you be subjected to a negligence case or a lawsuit and all that, to say the basic respect for persons and autonomy, to say a person has a right to choose their healthcare, and also informed consent, so say they have to participate in their care. You have to be able to show that even under these difficult circumstances, you still have to consider that, to say patients still need to give you informed consent, and if you have to override that, were there good reasons for you to do that. And the first do no harm principle will always apply, where they have to look in terms of whether you took into consideration to say you are here for the best interest of the patient and their well-being, and you were not intending to harm them. And that goes with the beneficence, which is also doing good for the patient, to say if your intention was to doing good, but again, your intention has to go with your level of training, or level of expertise, and your scope of practice. Because when you want to help, but you also just stepping into the field that you are not qualified to be in, that also exposes you to the risk of being subjected to a court case. And the other issue that as healthcare workers have to look at, to say, obviously, there's these human rights and this distributive justice that we've talked about, where you must also consider the limited resources. You must still respect people's human rights, but also make sure that there's equitable distribution of services between one person to another, because now you also become a manager of the resources during this time of the pandemic, to make sure that in a larger scale, when there's a lot of people that are now exposed to this pandemic, then you are able to share those resources, because you cannot just direct a lot of resources to one person and then neglect others. So those are things that I looked at to say, was it because there were limited resources, or maybe you had misplaced the resources or misdirected your resources? So those are things that they look at. Okay, so just as a guide to say, obviously for all of us, this is where you can find your code of professional conduct. It doesn't explicitly cover the times of COVID or a pandemic, but these are just core guidelines that as a professional and as a healthcare worker, you must always look at. There's one for health profession and the for Health Professions Council of South Africa, and also for the Allied Health, and also for the Nursing Council. Okay, so I'm at the end, but it's just a few questions that are frequently asked, which I'll also just throw in there, because I mean, there are no right and wrong answers, but it's all about whether it is being reasonable or unreasonable. Questions such as, do I have to see a patient if I don't have a PPE? And what are implications if I refuse, and the patient dies? Who's going to be held liable? Will it be your employer? Will it be you? So have to think about those. And what should I do if I'm now required to undertake duties outside my specialty or expertise? Do I refuse, or what do I do? So those are the things that doctors are exposed to. And also whether you can decline if you feel that the work you're asked to do is beyond your clinical competence. And also if telehealth is the way to go. Telehealth has now been changed, or this is what used to be called telemedicine. HPCSA has changed it to telehealth because now it covers beyond just medicine, which means even the psychologists and other people can do telehealth. It is seen as a good way to go during this pandemic, but this has limitations and challenges, because it might be limited to a patient that you already know, because you may not be able to fully examine and fully assess over the phone. But for somebody that you already know that maybe is a chronic patient to you, you can be able to do telehealth on them. Or for psychologists, for instance, where maybe all they need to do is counseling and psychological advice, they might be able to conduct the telehealth. So those are things that I wanted to cover this afternoon. And I think that takes us to the section for the questions.
Thank you very much. That was Dr. Tabani Kwanyana. Thank you for your contributions. We have, unfortunately, no time left at this point in time, given the very thorough and very detailed presentations we've had. Tabani, if you could unshare your screen.
Okay.
Thank you very much. And so at this point, I'm left with a minute or two just to say thank you to all of you. There was one last question. I see it's now been answered in the Q&A box, and essentially dealt with compensation matters, which we have done on a number of occasions on the previous webinars, and those webinars you will find on our website, that is www.nioh.ac.za, www.nioh.ac.za, and that website is zero-rated by all of the mobile service providers and one internet service provider. So please visit the NIOH's website. So at this point, I need to thank Dr. Brenda Kubeka, Dr. Marie Coombs, Dr. Frank Fox, and Dr. Tabani Kwanyana. Thank you very much for your contributions today to the ethical considerations of health and safety personnel in the workplace around COVID-19. And judging from the comments in the chat box in particular, I think to all of you, Dr. Kubeka, Dr. Coombs, Dr. Fox, and Dr. Kwanyana, there's been amazing positive feedback and comments on your contributions. and people indicating quite clearly that there may have been new information and new knowledge that they've gained also in this process, given the context of the particular challenge we face also within COVID-19. I'm not surprised. So thank you very much for your contributions. I'm unable even to ask you for final comments at this point in time. And so just to conclude, I need to just also advise everybody that if you've got any further questions, please email those questions to info, that's INFO, info@nioh.ac.za, info@nioh.ac.za, and we will also share those questions that you might have with the presenters, and to hear if they have any additional feedback for you. For those who asked about the presentation slides, it will be shared on the website. Again, that is www.nih.ac.za. Please visit the website. All presentations, audio and video recordings, as well as a host of posters and other infographics and useful resources you'll find on the website. Again, zero rated, the NIOH website. And just then, our next topic, and if I could just very perhaps briefly share that with you, and it'll take me a minute. I know we have reached the time, and so I'm going to quickly share with you the particular slide there. Our next topic is on the 18th of September. There may be another one just prior to that. And you will see that it is in collaboration with the South African Institute for Occupational Hygiene, SIO, on the 18th of September at 10:30 again. And we're dealing with a panel that will look at the issue of the use of fabric masks and masks with vents. So dealing with some of these key topics. I hope that that is also visible to you. But since you are on our mailing list and you have added your details in the registration form, we will be sending out the invite to all of you. So at this point in time, I need to thank a full list of colleagues, and I've now just lost that list. It is, I will send them an email directly, a list of colleagues from our occupational medicine section, our occupational hygiene section, our immunology and microbiology section, and I think including our toxicology and I think it's toxicology and microbiology, I'm not sure. The colleagues who've contributed, I want to say thank you very much to them for making their time and in order to monitor your questions and make contributions. So at this point in time, I need to say thank you very much to all our presenters, to you, the attendees for the session, as well as the many panelists from the NIOH that have contributed to answering your questions. So it's toxicology and it's toxicology and biochemistry. A colleague has just reminded me on the WhatsApp chat. And that's where we conclude our session today. Thank you very much. And please join us on our next webinar and visit our website. It is a very valuable place with lots of very useful resources for you to share with us. And to end off with a bit of our slides, as well as the, if I could just find it quickly, the soundtrack that we have. Oh, now I need to find my slides. One moment. As we conclude, then I was going to share our slideshow with you again. So there we go.